in the room. We are going to hold off for just a few minutes and to allow everyone to get settled, and we will begin the session officially at 5 past noon. Thank you for your patience. We will be with you shortly. Welcome everyone, and thank you for joining us today. Dr. Samia Ghanai, clinical toxicologist and senior specialist in poison information at the Department of Health. I'm the vice president of the Toxicology Committee at the ESEM. And it's my pleasure today to moderate today's webinar on this highly critical topic, approaching the sedated or sedated patients in the emergency department. Unexplained sedation in the ED is diagnosis and therapeutic challenge. Whether we are dealing with classic sedative hypnotics or other pharmacological agents, xenobiotics, capable of causing profound CNS depression, our approach must be systematic, rapid, and precise. To guide us through this, we are privileged to be joined by our esteemed speaker, Dr. Afra Alsuwaidi. Dr. Afra Alsuwaidi is a senior emergency medicine consultant and medical toxicologist with over 13 years experience in high acuity emergency medicine. She's Arab board certified in emergency medicine with fellowship training from Emory University at the US and an executive master's in healthcare administration. She's core faculty member of the Emergency Medicine Residency Program at the SKMC and co-chair of the National Toxicology Committee at the NIHS. While actively serving as an AHLS instructor, delivering specialized training across the UAE and the wider region. Welcome, Dr. Afra. And before I hand the floor over, I give quick notes. So please drop any questions you have into the Q&A box during the presentation, and we have reserved a dedicated time at the end to address them, inshallah. Dr. Afra Alsuwaidi, thank you for being here, and the floor is yours.
Thank you, Samia. Thank you, my dear, for the great introduction, and thank you for helping in moderating the webinar. Thank you for all our attendees and who are participating. As Samia she reminds, please, even for those who want to participate, they want to talk, we can easily unmute you if you have you want to share your thoughts, So let's start. I'm going to talk today about behind the veil, approaching a sedated patient and the emergency department, which I think that this is one of the most challenging, patient that we see in the emergency department. Of course, there's no disclosure. Let's start. So this topic, for me, even I would say that this topic considered very challenging for me, even especially before my fellowship, before being a toxicologist. So just a quick question, and I want you please to participate because this is a very interactive session. How many of you feel that approaching such patient when you know that this is tox related, low GCS, is a very challenging? Just say yes or no. Do you feel comfortable, seeing this patient, or is it challenging? So we have here yes. Okay, it is challenging. I agree. Anyone else other than Saba, or everyone else is comfortable? Okay, good. So we have here Dr. Soria. She's saying yes. It is challenging, but all right. Okay, good. Yes, challenging. Good. So today, my aim of my presentation today is basically to help you in processing. How would you approach this kind of patients? How would you manage this patient? And I want you to go. I will go with you systematically. So at the end of this presentation, I want you to think as a toxicologist as much as possible. Let's say that. Of course, as all of you, you know that when we are approaching such kind of patients, we need to have all our differential there. We have to think about tox related and non-tox related. However, for the sake of this presentation, we are going to focus more on tox related sedated patient. So I will start first with some cases, and I want your interaction. So please, write your thought in the chat. So you have a 20-year-old male found unconscious with active vomiting, and he developed generalized tonic clonic seizure while being transferred by EMS. ED presentation showed basically these vitals. As you can see, he is tachycardic, tachypneic, soft blood pressure, and temperature is normal. Saturation is well on oxygen, and GCS of 6/15. Examination is, as you can see, the pupils are 6 millimeter, non-reactive to light. Okay, just give me what is your differential diagnosis when we are thinking about tox. If you have some like drug in mind, also you can just throw it there in the chat. I'm gonna pause for that. Okay, we have here sodium channel blocker. Okay. Anyone else? Do you have any specific drug in your mind? Or even like, okay, TCA. What else? There is no wrong or right, so you can just share your thought. Okay, we have anticholinergic Toxidrome, and we have carbamazepine. Okay, good. Okay, so we have diphenhydramine. Okay, let's see. We'll go to our next case, and we'll try to see. We'll discuss later on what it could be. So let's go to our second case. Our second case is basically a 36-year-old male found unresponsive in the park. ED presentation temperature is 35.6, heart rate is 88, blood pressure is maintained, respiratory rate is 4. Saturation is 980 on room air. Examination is, this is the examination. So the examination is showing actually a GCS of 3, cyanotic appearance, pupil are pinpoint, and breathing is shallow. What is your like? Give me like either a drug or either Toxidrome if you would like to. Okay. Oh, I like it. Most of you are saying opioid. Okay, opioid Toxidrome. Okay, I agree with that. How many of you will intubate this patient? How many of you will intubate this patient? None of you will intubate? Okay, we have should be intubated. Anyone else would intubate? Okay, not immediately, support ventilation. Okay, I like that. Use naloxone first, naloxone. Okay, excellent. So let's go to our next case. So our next case, basically, we have a 25-year-old male found unconscious in bed by family. And basically, ED presentation is showing the following vitals. So patient is having a respiratory rate of 12, heart rate of tachycardic, maintaining blood pressure, saturation is 86 on room air. Examination is GCS of 11 over 15. A pupil's normal in size, equal reactive, gag reflex is intact. Other reflexes are normal. What is your differential of this case? What do you think? Okay, we have benzo. What other than benzo? What do you think? Okay, antidepressant we have. Okay, good. How many of you will intubate this patient? Antidepressant barbiturate, okay. Mixed sedatives. After ABC. Okay, good. So let's go to next. The drug overdose. Okay, I start to really admire the differential that you are giving me. Good, excellent. So let's go to our fourth case. Our fourth case is, so we have here a 48-year-old female found unresponsive with respiratory distress, intubated on arrival. ED presentation is showing the following vitals. So basically, heart rate, she's bradycardic, hypertensive, temperature, she's hypothermic. Physical examination, the following. Sorry, let's go back. Let's go back. Okay, so basically the physical examination is the following. Pupils are 2.5 millimeters, symmetrically reactive. Corneal reflex are absent. What do you think this could be? Okay, intracranial bleed. Okay, good. What else? A drowning, there's no history of drowning, basically. She was found in her bed. Okay. Okay, let's go next. We have here a pediatric 2-year-old male, accidental ingestion. So we know that he accidentally ingested something, altered mental status, presentation, the following vitals. So heart rate is 96, blood pressure is maintained, respiratory rate is 26. In the examination, decreased response, he's moaning, and his hypotonia with pupils are miosis. What do you think? What could it be? Let's go back. What do you think it could be? Okay, we have here clonidine. What else? Diazepam. Okay. Narcotic ingestion. Good. Okay, let's go next. So we have cannabinoid. Okay, this is good to think about cannabinoid. Let's go to our last case. So we have 70-year-old male with multiple comorbidities and intentional overdose as well. And he basically presented with GCS of 3, blood pressure is 90/60, heart rate is 120. Investigation was done, showed there's a QT prolongation or borderline, I would say. What's your differential? Antiarrhythmic agent, TCA. Okay. What else? Antipsychotic, antidepressant, good. TCA, good. Okay. So now let's go back to our cardiac toxicity. Okay. Okay, so let's go next. Let's do next. So how would you, how would you approach this patient? So approaching all of these patients is very important first. To think about how would you identify the poison. First of all, of course, in these cases, history is very important. However, history is very important. Your clinical assessment is very important, and then your laboratory testing. Laboratory testing sometimes it could, support your diagnosis, and sometimes it could mostly it can comes like completely normal. That actually will help you just to exclude other toxicity rather than confirming, confirming the toxicity or the diagnosis. So let's start with the history. What is important in the history that you really need to do when gathering information about such patients? So it's very important, to check and ask about collateral history. Although the patient history sometimes, we are talking especially now about sedative patient. Sometimes it's difficult to obtain that kind of history. So Collecting a collateral history is very important. And what I mean by collateral history is like bystanders, friends, family member, and also EMS. So what EMS see in the scene is extremely important. It can give you a clue, of what could be the ingestion, and this is very important. So always try, when you have such patient, to to speak with the EMS, speak with the paramedics, see what they found on the scene, how they brought the patient, what was the initial vitals, did the patient improve during transportation, or he was actually deteriorating. All of this can give you a clue of what could be the xenobiotic or the substance ingested. And in the same time, it's extremely important to review the patient medical file. So review the patient medication, patient previous history, psychiatry history, controlled medication. If the patient had, similar episodes or presentation to the ED with the similar symptoms, these are all very important. That can give you clue in taking history. This is the first thing. Second things, physical examination. So if anyone would like to take a pictures of this, I would advise, because basically this covers most of the physical examination that matter for us as a toxicologist. So when it comes to assessing the patient, and it also it will help you in creating your own like differential list of what could be the substance or xenobiotic by basically covering these physical examination. So for us, excuse me, for us, vital signs is extremely important. You need to see, is the patient is hypo or hypertensive. This is important. Tachy or bradycardic, hyper or hypothermic, tachypneic or bradytachypneic, or is the patient coming with completely normal vital signs? Each one of them will give you a clue. So, if we'll go more, we'll talk about method. For example, when you have like patient is coming with, for example, he's tachycardic, hypertensive, tachypneic, you will think more about such as anticholinergic, sympathomimetic. You will think about maybe possibility of these kind of drugs or substance. The same things when it comes to the pupil. Check the pupils. Is the pupils, it is the pupil dilated or constricted? There is meiosis, mydriasis. Is it reactive to light or non-reactive to light? There's nystagmus or not? All of this will give you a clue. So in toxicology, it's very important, to identify the toxidromes and treat the patient accordingly, uh, rather than identifying the agent itself. So knowing the agent exactly wouldn't much help you unless if you are thinking about, for example, reversible causes. For example, if it was opioid and you want to give naloxone, as antidote. Otherwise, approaching this patient, knowing what you are dealing with by only doing such physical examination, it can actually like help you deliver the care that the patient require. So when it comes to the skin, check if the skin is the skin wet? Is the patient diaphoretic? Is he dry? Is there any needle marks or medication patch that you are thinking about, for example, overdose? Or is it just normal skin? Check also as well muscle. Check also of course the peristalsis movement and the bladder. So is it active? Is it absent? Is it normal? Is the bladder distended? If we have a distended bladder, which toxidromes or drugs or group of drugs that you need to consider? I'm just gonna pause to allow you to comment on that. Good, anticholinergic. So this is what I want to highlight. Anticholinergic, it doesn't only happen in antihistamine medication. We need to keep in mind that many drugs that can cause anticholinergic effect because it acts on this receptors, So similar to what? Similar to TCA. TCA can give you anticholinergic syndrome. For example, as well, many of antipsychotic medication can give you anticholinergic toxidromes. That's why think about this when you are approaching this patient. Sometimes patient with delirium or agitation cannot really report that they cannot void, and this is very important to examine this. If you are not sure if the bladder is distended or not by your physical examination, just grab the ultrasound and do a quick ultrasound and see the volume, you know uh, um, you are right, antispasmodic as well. So other than this, is check the muscle tone. Is there rigidity in the muscle tone? Is there's like a lead pipe rigidity? Is there's hypo or hyperreflexia, or there's a clonus? So you will build your differential by this, by doing this physical examination. And I mean, we can pause, or do you want to keep your questions at the end of the presentation? If you want us to pause, if you have a question, I can pause for a while. Okay, let's go. Good. At the end, you prefer it at the end. Let's do it at the end. Good. So let's talk about the toxidromes. What toxidromes you have to keep in mind? So we have the anticholinergic, as we said. Anticholinergic, of course, they initially they can come with abnormal vital. I would say they can come with hypertensive, tachycardic, with the respiratory rate is high. I mean, later on they can have like I mean, they become delirium, agitated, and then they can develop also a hyperthermia with that. Keep in mind that I mean CNS depression and anticholinergic toxidrome is actually very late, so it happens late. Before that, patient can be like agitated or delirious. Pupils, as usually they have usually mydriasis, dilated pupil, and when it comes to the peristalsis movement, it's decreased, as we said. And keep in mind that they can have very dry skin, and with a flush with red skin as well, and urinary retention. And sometimes part of their, I mean, agitation can be because of the urinary retention, and they cannot really communicate that, you know. When it comes to the cholinergic initially, they can present with like tachycardia, hypertension, but later on they develop the opposite. They become bradycardic, hypotensive, severely sick, you know. Mental status also, they can present initially normal, but then they can develop CNS depression as well. A pupil, as we said, it can be like fluctuating between mydriasis and myiasis, since cholinergic toxidrome usually it affects both muscarinic and nicotinic receptors. And usually they are very wet. They are like basically having over like secretion, salivation, lacrimation, urination, all of that. Let's go next to our toxidrome. So, like, okay, this is good. When we talk about ethanol and sedative hypnotic, actually ethanol considered part of sedative hypnotic, because both of the ethanol and sedative hypnotic, they act on the same receptors in the brain. They act on GABA receptors. So usually ethanol and sedative hypnotic literally can present the similar when it comes to the vital signs and physical examination. They will come with like either normal blood pressure, or like or I would say soft blood pressure, or like hypotensive. The same with the heart rate. It can be normal or a little bit like toward the bradycardia. Respiratory rate, it can be, I mean, normal or little bit maybe decreased, but of course not like opioid when it comes to opioid. And the temperature is usually it is characteristic of ethanol and sedative hypnotic. In overdose, they can cause actually hypothermia, and both cause CNS depression. Of course, both of them, they have normal pupils, a decrease in the peristalsis, and normal skin, so they wouldn't have like any dryness or diaphoresis. Reflexes also, they will tend to have like hyporeflexes, hypotonia, similar to the opioid. However, what distinguishes the opioid from sedative hypnotic? Two things I would say distinguish opioid from sedative hypnotic. First of all is the meiosis that usually happen in opioid. And the other things is that with the opioid, I mean, usually the I would say usually the vitals tend to be more like depressed. Like for example, they will have more blood pressure, heart rate, respiratory rate is really affected in the opioid compared to sedative hypnotic. So sedative hypnotic, they will have like they can have up to 14, 12, I would say 12, 10 respiratory rate, but when opioid it can go more than that. Let's go next. Okay, so what are diagnostic tests you need to order? Of course, I have just listed these tests, but it doesn't mean that you have to order all of these tests on each patient. This is just to direct you what a blood test you need to consider. And basically, sometimes, as I said earlier, that sometimes we order some blood tests not to confirm the diagnosis, to exclude other toxicity actually, and to make sure that we are not missing something, you know. Of course, CBC, lights, I mean, liver function, I would say renal function, serum lactate, of course, if you are suspecting, for example, other toxicities such as gases, cyanide toxicity, CO toxicity. metformin toxicity, such of these, then of course these can help you, serum osmolarity, especially if you are like suspecting toxic alcohol. Venous blood gas is extremely important. You need to check the pH, especially that it can give you an early clue for salicylate toxicity, and then a drug level. I would say the most important drug level that you need to order is acetaminophen. And why is that? This is important because basically acetaminophen is the most like co-ingested drug. First of all, second of all, is available in most of the household, and it's over the counter. So acetaminophen, I think it is like big mistakes if someone like would not detect or like catch acetaminophen toxicity, an overdose or suicidal attempt. So of course, in any patient with the childbearing age, female, definitely do urine pregnancy test. ECG, of course, is really important. ECG is important, to rule out any like QT prolongation, QRS widening, any tachycardia or bradycardia, So ECG is important while you are doing, your assessment to these patients. Images depend. Of course, I would say CT scan for any patient with the depressed CNS, definitely head CT scan is extremely important. You need to rule out other pathology. Even when you think like almost you are sure this could be tox related, still like if there's like 1% you are not comfortable, then definitely go ahead and do CT head. Let's go next. So what are the drugs that you need to consider when we are talking about sedative hypnotic or drugs that may cause CNS depression? So sedative hypnotic is actually, most of us think about, benzodiazepines, but benzodiazepines is only one group of these drugs. It could be the non-benzodiazepines, such as the Z group. You could have barbiturate, can cause similar symptoms. And then you could have chloral hydrate, which actually, unfortunately, very often used by the pediatric. We have also the propofol, etomidate, bromides. All of this can give you similar sedative hypnotic presentation. We have the dexamethasone, which actually a common drug that used in the ICU setting. So what other drugs to consider? Anti-epileptic medication can give you the sedative hypnotic effect. Baclofen does that. Anticholinergic medication, antihistamine, GHP as well. Ethanol and toxic alcohol, all of them, they consider CNS, they cause CNS depression. Opioid, antipsychotic, and antidepressant, all of these drugs. And actually, there's more than this. So what is your management? Your management is always, approaching the patient by ABC. First of all, assess the airway, breathing, and circulation. Okay. So how many of you here would intubate a patient with GCS like below 9? Quick question. I'm waiting for your answer. How many of you will intubate a patient with a GCS below 9? Okay, we have yes. We have here someone will say below 7. Okay. Not always. Okay, good. Okay, we have another answer, should be intubated. Okay. It depends on the case. Okay. I agree with that. It should be dependent on the case. Okay. Not automatically. Okay. So you will wait and you will assess the patient. Case by case. Okay. Oh, okay. So let's talk about this very interesting, very like I would say practice changing paper. So this paper, basically what they did, they did a paper of, they involved almost, this was a randomized clinical trial. There was, multiple centers were involved, although if I'm not mistaken, like 40 emergency department, one ICU involved in this study. So they actually, what they wanted to do, check the effect of non-invasive airway management of comatose patient with acute poisoning. So what they did, they divided the group into two groups. One group received a conservative management. Okay, so let's start from the beginning. All of the patients who are involved in this study had a GCS of 9 and below. Okay, this was one of the criteria for inclusion of this study. All of these patients had low GCS due to toxic related. So it wasn't medical, it wasn't, God forbidden, like medical or like, for example, CNS bleed or stroke or any of other these things medical. It was mainly tox related. And basically, they divided the groups into two groups. One group received, the usual treatment, which actually a patient need intubation, they will go ahead and intubate the patient. The other group, they did a conservative management. So they just supported the patient with oxygen if needed. What they found, and they wanted to study basically a few things. They wanted to study the complication, the length of the stay, in the hospital, the length of the stay in the ICU, and then overall the patient how they did. And they found that the patient with conservative management, when they did not intubate, went ahead and intubate, they did actually much better. So the length of the stay was shortened, the length of ICU stay was shortened. There was no complication due to mechanical ventilation or acquired pneumonia that usually can happen with the prolonged stay. And overall, the patient who were managed only conservatively did much better. So what does this tell you? It tell you that basically when you know that this case is a sedative hypnotic or this is a CNS depression due to tox and patient is maintaining his airway, and this is extremely important. I'm emphasizing on patient maintaining their airway, or if they are not maintaining their airway or breathing, for example, there is something you can do to reverse that. For example, such an opioid, you can reverse it with naloxone. Then definitely you can, manage this patient conservatively. You don't need, to intubate them. Let's go ahead and continue. Uh, what else you will assess? Of course, we said about our ABC, then our D, of course, you will need to assess disability, assess the CNS, check if the patient, CNS, GCS, pupils, all of that. Of course, if you could, by this assessment, if you could assess the toxidromes or identify the toxidromes, it will be great because many toxidromes can be identified by history and physical examination, to be honest. Of course, and then you have to place your diagnostic investigation. What do you want to work up the patient with? Let's go next. So at this point, if the patient, how many of you would like, give charcoal in patient with low GCS? This is a question. You can share your thoughts. How many of you would give a charcoal for a patient with low GCS? Sorry. Okay, no charcoal. Not using now, no. Okay. Contraindicated. Good. Okay, good. I really, okay, I admire that. Yes, you are not supposed to give any patient a charcoal when they are having a low GCS. However, the only time you can consider giving charcoal, I would say generally, this doesn't apply on sedative hypnotic, but I would say generally is the patient who basically you are worried that whatever they ingested is severely toxic, and basically you want to protect the airway by intubating the patient. So the moment that you intubate the patient, you protect the airway, then you can insert an NG tube and give the charcoal. Okay? Good. So, consider alter toxin pharmacokinetic. For example, such as, for example, I wouldn't say orogastric lavage because we don't really use it, but I would say, for example, consider activated charcoal, as we said. However, you can also consider whole body irrigation in such a patient when you think that the xenobiotic ingested is very toxic. Of course, and then consider also enhanced elimination, such as multiple dose activated charcoals with a protected airway, sodium bicarbonate, hemodialysis, and these things, depending, of course, on the xenobiotic. So let's go next. So let's go back to our cases just to keep up on time. And this is just a quick reminder of the cases. So this is just fresh reminder. This is the case. Let's go now to what happened to this patient, if you remember, just quickly. So what happened to this patient basically? So this patient, developed this kind of ECG. Anyone want to comment on this ECG? Okay, good. White QRS. Oh, TCA, again TCA. Okay. Okay. So basically, this patient developed a wide QRS. I agree with that, tachycardia. However, this was not a TCA overdose. This was actually a massive diphenhydramine overdose. Keep in mind that diphenhydramine may cause sodium channel blocker effect. So this case was actually a case of diphenhydramine overdose, and this is what happened to the patient. So basically, patient unfortunately, he developed wide complex tachycardia. He deteriorated, sudden asystolic cardiac arrest. CNS was like started. He was then actually put on ECMO, established within 30 minutes from the cardiac arrest. The outcome, he had, normal conductive restored within 24 hours, treated with sodium bicarbonate and ECMO, and basically, patient survived. By the way, all the cases are here are actually real cases for a real patient, and it's actually all published. Let's go to our next patient. Next patient is simple and straightforward, I would say. This is a case, as you can see, this is an opioid case. So that's it. Like patient survived with naloxone. Patient received naloxone and he did well. Let's go to our third case. So this is just a quick reminder of our third case. It was a 25 female male found unconscious on bed. And basically by family, this is the vital signs, as you can see, and this is the examination. So what happened to this patient? What happened to this patient? Uh, what happened to this patient is this. This is how the case progressed. It progressed that the patient started to deteriorate. Suddenly, he became hypotensive. Blood pressure was 75 over 45. Intervention patient was started on phenylephrine infusion. He was started on noradrenaline. He was additional history family. They tell you that they found an empty medication strip under his bed. What do you think this was in the ingestion? Any idea? Okay, so interestingly, that this patient ingested uh, clozapine, which it is benzo. However, it turned later on that he had mixed ingestion. He ingested actually clozapine with amlodipine. And when the family came and they showed the strips, the empty strips, it was actually amlodipine. That explained how the patient deteriorated. Because if the patient ingested only clozapine, he wouldn't become that much hypotensive. He wouldn't like deteriorate in that way, you know. So this is what I need you to learn from this case is that you always when things doesn't it doesn't it doesn't it is not explained well when you think that there's something wrong when you are not happy like the symptoms does not match the xenobiotic. Think about co-ingestion, think about mixed ingestion. So this patient was started on high dose insulin basically and he survived well. Let's go to our fourth case. Our fourth case is basically this patient who were unresponsive with the respiratory distress, intubated on arrival, bradycardic, tachycardic, hypothermic. Examination is low GCS, non-reactive, dilated non-reactive pupils, and corneal reflex absent. So this patient actually went through a thorough investigation, neurological investigation. His examination was consisted of a brain death actually. Patient has absent corneal reflex, absent oculocephalic reflex, no gag reflex, absent deep tendon reflex, diffuse hypotonia. Within 24 hours, he was extubated, neurologically improved, and within 48 hours, full neurological recovery. What do you think this was? Anyone? What do you think this case is? Okay, barbiturate we have here. Okay, what else? Literally, like this patient, he was almost brain dead, and then he fully recovered. A neurotoxic snake bite, okay. Organophosphate, baclofen. Oh, good, excellent. This was a case of baclofen, actually. So baclofen is one of the few drugs that can mimic brain death. So keep in mind that patient with baclofen overdose, they need a prolonged prolonged, supportive therapy, even if that means that they have to be on ventilation till the drug wash out from their body. So baclofen is one of the few drugs that can mimic brain death. That's why when we have baclofen, we do the support management for a long time till the patient recover, and they do recover very well. Okay, so let's go to our fifth case. This is a 2 years old male, accidentally ingested, overdose, altered mental status. This is the vitals, so we can say, and pupils, they're showing meiosis with, decreased response and hypotonia. So basically, the investigation was unremarkable, ECG, sinus bradycardia. So atropine was given, but there was no improvement. So what they did, basically they called, this patient was a case of clonidine overdose, and the poison center was consultant, and they advised for naloxone. Usually with clonidine, even with clonidine overdose, especially if you know that this is clonidine, you need to understand that they don't respond with the low dose of opioid of naloxone. So you really need to give them high dose. Before you have to go, like, you can give up to 10 milligram of naloxone to this patient, and you can keep on repeating the dose basically till you escalate it to 10 milligram. Okay, let's go to our last case. Our last case is the 71-year-old male with multiple comorbidity, intentional overdose, ED presentation, GCS of 3, blood pressure not bad, but it's tachycardic QT prolongation. So what happened to that patient? What happened is that the patient basically post-ingestion, he was intubated. He developed severe hypotension, and he was treated with ringer lactate. Day 3, he had an agitation episodes. Day 5, he has septicemia and treated with antibiotic. Day 10 and day basically 18, he had SVT episodes, multiple SVT episodes treated with adenosine. So the outcome, basically, patient completely recovered without any residual symptoms. What do you think? What do you think the xenobiotic here? Give me your differential. So basically, this was a case. Okay, we have methadone. Okay, TCA, methadone, antipsychotic. What else? So, Azza, excellent. It was an antipsychotic. It was actually a quetiapine, long-acting quetiapine, a drug that caused that, it resulted on. It wasn't, no, it wasn't antiparkinsonian. It was actually quetiapine. Okay, so that conclude our cases. So what are the things that I really need you to take? What are the takeaway messages? What I need you to take away messages, the key points of this presentation. I would say always when you approach patients sedated due to tox-related, ingestion, always be systematic in your approach. Always address the airway, breathing, circulation, do your ABC. Third things, if you have a reversible cause or reversible agent, then please do that. Like use naloxone in case of opioid. Your aim when you are using naloxone and opioid is actually to reverse the respiratory depression, not the CNS depression. Keep that in mind. Always, of course, consider co-ingestion, especially when the clinical finding does not align with the diagnosis. Always, it's good to take history from the patient. However, it's always keep it in mind that it is unreliable, and therefore you have to go with a broad differential diagnosis when assessing this patient. Thank you all. That conclude our presentation. For those who want to connect, through LinkedIn, please, just scan the barcode. Thank you so much. Now we are going to open the floor for any question.
Thank you so much, Dr. Afra, for sharing your expertise in this with us today, and to all of our attendees for the active participation in the chat. Also, we are waiting for any questions you have, and anyone would like to even speak, we can open the mic. If you have any questions. One thing I wanted to highlight regarding regarding this regarding the silent co-adjustant. This is really important for a profoundly sedated patient where the history is unobtained. For us, it's easy to say it's a sedative agent, and however, we strongly advocate or think about screening the silent killers, like testing that we have paracetamol and salicylate. Exactly why? Because given sometimes we don't have reliable history, and intentional overdoses are frequently polysubstance. And as you said, Afra, the household contains the paracetamol and salicylate and more paracetamol. So that's why so they can, and even they can be, the patient can be entirely without significant symptoms of paracetamol or salicylate toxicity in early phases, while causing the fatal hepatic and metabolic damage. That's why every patient presenting with intentional overdose or undifferentiated altered mental status should have or receive this screening for this agent, regardless of how obvious the sedative toxidrome appears.
Great, Dr. Samia. I think there is a question here in the chat. We can answer it. Is CT scan justified in all alcohol intoxication patient with low GCS? If you are sure, okay. Okay, this is beautiful question, basically. So I would say the answer is no. It's not justified in all the alcohol intoxication patient because it should be case by case. So let's do that. So if the patient is basically under intoxication, and you know that this is alcohol, because usually alcohol you can never miss the smell of alcohol. The moment that you enter the room, you would smell it. This is one thing. Except the only exceptions would be when patient, he's naive and then he drink alcohol. So the amount that he drank is not that much, or he drank beer, maybe this maybe less likely you would smell the alcohol. But otherwise, most of the type of alcohol you would smell it, because part of their metabolism actually get metabolized by the lung. So that's why to make the smell is very distinguished. So I would say that if a patient is actually, that this is alcohol intoxication patient, while he's sitting there, there's no history of a trauma, or there is no signs of a trauma, because this is extremely important when it comes with intoxicated alcohol, because most of them they go through either like a fight or a conflict, and then they end up having being assaulted, or accidental fall. So sometimes when the ambulance bring them, there is no clear history. So that's why you need to go and do a thorough physical examination. Check if there's any sign of a trauma. Make sure that the pupils are bilateral, active and reactive. This is very important. Will tell you, okay, less likely I'm gonna go and do CT scan or not, because this patient you want to rule out bleed, because they do tend to have this kind of trauma, with intoxication. One thing. The other things I would say, if the patient is, let's say you did ethanol level, because I would advise to do ethanol level for this patient. Do ethanol level and see, does it correlate with the patient CNS depression? If it doesn't, if the ethanol is not that much high, then you have to also raise suspicion. This could be something else, and the patient is still let's say he's sedated, not responding, to you, even if he's maintaining his vitals. The other things I would say, if you have an emergency where you can observe the patient for a couple of hours, give a fluid. I always notice that when you give patient with the alcohol intoxication fluid, usually their symptoms of or CNS depression improve. So if the patient starts to awake, his CNS start to improve, GCS improve, but then less likely you need to go ahead and do CT scan. But if the patient remain the same, then I would say yes, definitely consider CT scan, like low GCS, not really waking up, not responding. So I hope that answered your question. This is how would I approach these patients, like case by case. Okay, then we have, I think, another patient. If patient is having If patient is having persistent vomiting, like vomiting non-stop after ingesting intentional naproxen and colchicine tablets, should we intubate? I would say yes, definitely intubate, because colchicine is very highly fatal drug. So I will intubate not only for that to protect the airway. I will intubate because I want to be very aggressive with this patient. I will make sure that I will give activated charcoal, and mostly I will start also whole bowel irrigation. With ethanolic, okay, I'm not sure ethanolic. Okay, we had a lot of experience with these patients on weekends, and though their GCS3 initially can be trouble fever. Okay, I agree with you. A brain injury biomarker in the future may be useful way to decide on imaging need. Okay, excellent. Yes, I agree with you. Many of the actually alcohol intoxication, they have very low GCS. As long as they are maintaining their breathing and airway and breathing, I will let them sleep as long as they want. As I told you, I will give a fluid because I noticed fluid actually make them more awake or more sober after a while. Uh, okay, thank you. And I think we have another question was there on this on the chat about decontamination. So for to answer that question about the decontamination, external decontamination, you can do it in the ED by using water and soap, basically. That's it. You can do any kind of contamination by using these two. You don't need any special agent for decontamination other than water and soap. I hope that answered the question. Thank you, Dr. Samia. Please, if you want like to add anything, please do that.
Thank you so much, Afra, Dr. Afra. I think we have here as well another question. Let me check it out.
So I think that maybe we can wrap it up.
We have another question, I think, regarding if the patient is having persistent vomiting, like vomiting non-stop after ingestion and intentionally naproxen.
We answered it, Samia.
Yeah, this is already answered.
Yes, that's.
And we have, other one last question, yeah.
Okay, thank you all. Thank you for joining us for today. I really appreciate each one of you. Thank you for supporting our webinar. Please, if you have a few moments that you can, evaluate the webinar, it will be really great so we can, improve, and I hope you join us for our next webinar. It will be actually on the 21st of May because we are going to, make it earlier because of the week of Al-Eid. Please join us for that. It will be a pediatric talk presented by Dr. Lara.
Yeah, thank you, Dr. Afra, for the insightful and excellent talk today. Thank you all for joining us, for your active participation and excellent questions. And please join us in our next Poison Hour, also in our clinical rounds as well, sessions. Thank you all again. Stay safe and have a wonderful rest of your day.